A very good morning to all of you. To start today's session, I would like to invite all of you to join in our very interactive webinar. So today the webinar link will be available from 9:50 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. These programs are maintaining high standards so that these CPD programs will be adhered according to the CPD regulations, and we really appreciate your kind compliance. Today's lecture is one of our very most interesting lectures in the CPD program, and this is jointly co-organized by the Government Medical Officers Association and the Society for Health Research and Innovation. Without further ado, I would like to ask you to switch off your videos and also to mute your microphones to avoid any disruptions. And as usual, there will be a Q&A session at the end of this webinar to submit your questions so that we can clarify any problems that you have after this webinar. Today's topic is going to be individualized approach to the management of diabetes, which will be a case-based discussion. Without further much ado, I would like to introduce to you our distinguished speaker today, Dr. Kamani Liyanarachchi, who is the consultant endocrinologist at Teaching Hospital, Ratnapura. Over to you, madam.
Thank you so much. So let's go on to the first case. So this is a common scenario in our clinical setting. We finish our clinic and the staff nurse comes to you. Will come to the clinic. She wants to show you her reports. So she's actually a 55-year-old. She's obese obese lady, and she has done her HbA1c, which is 6, and then the fasting blood sugar is 110. So this is an easy scenario to start off. So my question is, which statement is true regarding her condition was the MCQ. So what is her condition actually? So actually what she is having is it diabetes? It's not diabetes, but it's not normal either. So this is actually pre-diabetes, which is the it just shows us that diabetes is ahead. So how would you diagnose diabetes? So these are the criteria for diagnosis of diabetes. You can see that these are adapted by the WHO in 1999. Before that, the WHO took fasting blood sugar level as 145 to diagnose diabetes. So why did they reduce the sugar level to 126? So if someone is having a fasting blood sugar of 126 or more, you take it as diabetes. So this is actually the first people to propose this 126 was the ADA expert committee. What they found out was that we know all these patients with diabetes, they get micro and macrovascular complications. So out of these complications, retinopathy was one complication which was directly related to the blood sugar level. So for example, if you take nephropathy, it will also be affected by blood pressure. But retinopathy was purely affected by the blood sugar level. So they found that the level of retinopathy only occurred after the fasting blood sugar of 126. So they thought, yes, so this is the cutoff where people develop this condition, which is very unique to diabetes. So they took the fasting blood sugar as 126. The AD expert committee took this, and then the WHO also adapted this level. Now, how long should you fast for a fasting blood sugar? Sometimes even that is a question for us. So actually the American Diabetic Association tells that you need to fast for 8 to 12 hours. So it's a range. So routinely we usually give 10 hours because it's the middle. But if you are doing the fasting, the lipid profile along with the fasting blood sugar, you can fast for 12 hours or even 8 hours is okay. So confirm the diagnosis of diabetes. The other factor is the postprandial blood sugar. So the ideal way is actually the post-glucose challenge or following the oral glucose tolerance test, if they have a 2-hour postprandial sugar of more than 200, so that is the ideal way, but that is not a must. Was the ADA expert committee. What they found out was that we know all these patients with diabetes, they get micro and macrovascular complications. So out of these complications, retinopathy was one complication which was directly related to the blood sugar level. So if you, for example, if you take nephropathy, it will also be affected by blood pressure. But retinopathy was purely affected by the blood sugar level. So they found that the level of retinopathy only occurred after the fasting blood sugar of 126. So they thought, yes, so this is the cutoff where people develop this condition, which is very unique to diabetes. So they took the fasting blood sugar as 126. The AD expert committee took this, and then the WHO also adapted this level. Now, how long should you fast for a fasting blood sugar? Sometimes even that is a question for us. So actually the American Diabetic Association tells that you need to fast for 8 to 12 hours. So it's a range. So routinely we usually give 10 hours because it's the middle. But if you're doing the fasting, the lipid profile along with the fasting blood sugar, you can fast for 12 hours or even 8 hours is okay. So then, confirm the diagnosis of diabetes. The other factor is the postprandial blood sugar. So the ideal way is actually the post-glucose challenge or following the oral glucose tolerance test. If they have a 2-hour postprandial sugar of more than 200, so that is the ideal way, but that is not a must. So if a postprandial sugar after meals is more than 200, then that also we can take as a criteria. And then HbA1c more than or equal to 6.5. So these are the 3 criteria. But unless a patient has classic symptoms of diabetes, we can't take just one criteria just because one person is having a mild HbA1c level of 6.5, just one reading. If he doesn't have features of diabetes, we cannot diagnose. So what features are we talking about? We are actually talking about osmotic symptoms. So fatigue is one symptom, because we know that diabetes is called as starvation amidst plenty. That means you have plenty of sugar, but your cells are starving. So one feature of diabetes is the cells are starving, because so the patient will feel fatigue. But the classic features of which we are talking about here is actually the osmotic symptoms, where the patient will have thirst, polyuria, and also weight loss. So if someone has classic symptoms of diabetes, just with one reading, you may be able to diagnose, especially when the blood sugar is above 200, a random level, or with one of these criteria, one of these levels, if you have classic symptoms. If not, you have to repeat the test. Can we move to the next slide? Okay, so what is pre-diabetes? So pre-diabetes is fasting blood sugar. So normal fasting blood sugar is taken as less than 100. So in between that, you call pre-diabetes, and then the plasma glucose following OGTT in between the normal and the abnormal, and the HbA1c in between the normal and abnormal is taken as pre-diabetes. So pre-diabetes is actually telling us that diabetes is ahead. So that is the important thing. So actually, it's not only that. So you get, if you look at the traffic light system, if the red is diabetes, pre-diabetes is the yellow, green is you are okay. So you're about to get into trouble. That's what it means. So problems with pre-diabetes is not only the progression to diabetes. There are other complications like microvascular and macrovascular complications. So as I said, macrovascular complications are common, but some microvascular, especially retinopathy, is rare. I mean, not seen almost, but in medicine, we know we can't say 100%. So retinopathy is very rare because we have taken this 126 margin for the onset of retinopathy, but microvascular complications, particularly neuropathy, can happen in patients with pre-diabetes. So you would have known there are so many patients who are regularly checking their sugars, but they are not having diabetes. They are in the level of pre-diabetes, newly diagnosed. When they step into diabetes, they will complain of numb feet, and that is actually due to the pre-diabetes condition. So pre-diabetes will have some microvascular complications, particularly neuropathy, but also sometimes proteinuria nephropathy. Right, so this is one of the landmark studies called the DPP, Diabetic Prevention Program. So what they did was they took these people who were diagnosed with pre-diabetes or impaired glucose. So pre-diabetes has two things. You can either have the fasting blood sugar being impaired or the postprandial sugar impaired. So impaired. So these people were taken in, about 3,000 patients were recruited, and then they divided this group into three. The placebo group, some were given metformin, some were given lifestyle modifications. So now when they followed up the people in the placebo group, they found that 5-year incidence of progression to diabetes is this much. So it depends on your HbA1c. So roughly you can remember, if your HbA1c is about 6, the next 5 years there is 1/4 to half chance of you developing diabetes. So, right. So now what is this lifestyle modification they talked about? So here they targeted at least 7% of body weight loss with at least 150 minutes of exercise per week. So that is the target given to this group of patients who adhered to this, and the other group was given metformin 850 daily or BD. Right. So you have these three arms. So when they followed up this group at the end of 3 years, they found now in the placebo group about 30%, that is 29-30% developed diabetes as an average. So the ones who got metformin, only 22%, which was a 31% reduction. But the most important thing you will see, almost 60% reduction in the intensive lifestyle intervention group. So what this says is losing weight and exercising can really take you a long way, right? So this is used nowadays. So these new studies about diabetes remission, I think you might be interested in this area. So diabetes remission, this is one of the important studies done regarding this, called the DIRECT study, done in the United Kingdom as a community study. So what they did was they took about 300 people who are actually obese, and then they made them they divided into two, and then they made them lose weight. One group they targeted to lose a lot of weight, and then the other group they did the best treatment, which is currently available in the guidelines. So what did they do? So they did, when these people who were about to lose a lot of weight, they gave meal replacement, which only gave about 850 calories per day. This was given for 3 to 5 months. So they were actually given things like soups and shakes, like so Optifast and all. So they were given, and then these group of people, after 3 to 5 months, they were gradually introduced to food, but then the weight loss was maintained. So the results were actually at the end of 1 year, 10 kilogram. So there was a 10 kilogram weight loss on average, and there was remission of diabetes by 1 year. Right. So what is this remission of diabetes? When we were medical students, we were told, okay, if you get diabetes, there's no remission. You will always have to drink your tablets and control your sugar to prevent complications. Now, this remission of diabetes is a new concept where we try to remove the the pathogenesis of diabetes. Now, what is this? So, in this, actually, what happens is when you're obese, you get insulin resistance, you get high fat level in your liver. So the liver produces more and more glucose, which is, and then also it produces more and more triglycerides. So because you have produced more and more glucose, when you have insulin resistance, the liver produces more glucose, you get higher blood sugar level, more and more triglycerides. These triglycerides goes and gets deposited in the pancreas, so causing increasing pancreatic fat also. So they found that increase in pancreatic fat causes these beta cells to temporarily get into dysfunction. So this is a nice diagram showing an MRI scan where a patient who had significant amount of fat. So the fat amount, so you can see the greenish color in the MRI showing about 36% of fat. Only 2 months of this low calorie diet, and you can see the liver fat has come down a lot by had come down to 2%. So you can see that by this type of low calorie diets, the dramatic reduction of fat is seen in the liver. So basically, in the direct study, at the end of 1 year, the 24% of the patients lost weight, and then diabetic remission was seen in about almost half of the people, and in the intensive arm, and then 74% were able to discontinue the drugs. So the other thing is so this blue bar is the intensive arm, and the light blue one is the conventional therapy, the control group. So this was in the end of 1 year, and then in the second year also, when they maintained the low weight, this remission of diabetes was seen at least in more than about 30% of people. Okay, so again, going back to pre-diabetes, some of the groups, so going back to the DPP study, some of the people who were given metformin, we said that metformin was not actually as good as lifestyle modification. But if you analyze the subgroup, the subgroup people found that if someone is very obese, like BMI more than 35, with there's a history of GDM and younger age group, particularly less than 44 years people, they responded as much as, they had a very good response as much as the lifestyle modification. Okay, so the other important thing about pre-diabetes, the other important thing we need to address is the cardiovascular mortality. So, these are the status of cardiovascular risk. So this we need to tell our patients, because, normoglycemic patients, you compare the normoglycemic patients, the bottom line, the diabetic patients are about 4 times higher at developing cardiovascular mortality, and the impaired glucose tolerance is half of that, about 2.8%. So these people are also at risk of developing diabetes related cardiovascular mortality. Right, so we need to look for, so the ADA recommends that we need to screen for the cardiovascular risk factors. So once when someone develops pre-diabetes, we need to look for other cardiovascular risk factors which are modifiable, like smoking or sedentary life. So those we need to modify. Okay, so how would you progress? Now we know that some of these people will develop diabetes. How would you progress? Would you monitor the fasting blood sugar? What would you monitor, the postprandial sugar or the HbA1c? So this is the diagram which gives the answer for this question. So you can see now most of our patients, actually the IDF mentions that half of our diabetic population is undiagnosed. So when by the time you are diagnosed, you have gone some way in having diabetes. So before you get the down bar where you have the green bar, which is type 2 diabetes, before that you get the pre-diabetes. So you can see macrovascular complications and microvascular complications set in during the pre-diabetes era also. And when you look at the fasting blood sugar and the postprandial blood sugar, the first one to rise is actually the postprandial sugar. So this is in this study, but universally it is not true. So just by monitoring a postprandial sugar may not be enough, because in some patients it's the fasting blood sugar. This is not universal. So so we need to, the best way forwards maybe the HbA1c. Right, so let's talk more about HbA1c. We know what is HbA1c. We have the hemoglobins, and the hemoglobin has alpha and beta chains. So when you have high sugar, when you have blood sugar, the sugar molecules get glycated into this beta chain. So the amount of sugar level in your blood can be assessed by checking what is the percentage of your red cell glycation. So we know that red cell half-life, when we were in the medical school, we were told that it's 120 days. So it's actually taken as 90 to 120 days. Now, this HbA1c, so that's what we say. So we take this 90 days and we say, okay, HbA1c tells your blood sugar level during the last 3 months. But actually, studies have shown that this is not actually 100% true, even though it is somewhat true. The last month, the last 30 days is accounting for most of the level. 50% of the blood, the HbA1c is governed by the level of blood sugar in the last month. So if you repeat your HbA1c in 2 months, you cannot be blamed. So people can say, okay, why is it wrong to do it in 2 months? No, it's not, because actually the most effect is from the last 1 month. And another interesting thing is seen in this chart, that you can see there are black bars and the white color bars. The black bars is for the fasting hyperglycemia. The white color bars are the postprandial. Now the bottom line shows the HbA1c levels. So you can see when the HbA1c is more than 10, it's mainly the fasting blood sugar which is affecting. But if the HbA1c is less than 7.5, it's mainly the postprandial blood sugar. So how would you take this into clinical practice? So if your patient is having a very high HbA1c, then you need to know, okay, if you only have the HbA1c, the idea is that this patient's fasting blood sugar is very high. And if you have a patient with the HbA1c 7.5, is a 7.3 or low, then that means you, to improve further, to make it 6 or 6.5 or something, you need to improve on the postprandial sugar. So that is the implication of this slide. Okay, so right, what are the factors affecting HbA1c? HbA1c is not always right. So factors which affect the red cell half-life will affect the HbA1c level. For example, if you are pregnant, then your red cell turnover is high. So your HbA1c will be falsely low, because the red cells are dying faster, producing faster. So there's no time for these red cells to be glycated. So similarly, hemolytic anemias, hypersplenism, all these things will have a falsely low HbA1c. Whereas when you have low red cell turnover, like in deficient anemias, you will have like even in chronic renal failure, there is erythropoietin deficiency. So the red cells are producing very slowly. So then also you get a falsely high level of HbA1c. Things like alcoholism can increase glycation of the glucose to the hemoglobin, hemoglobin. So that's why you get a falsely elevated level in that, right? So there are other tests. So if you have like if you have a problem with your HbA1c, then you can do other tests like fructosamine, which checks how much sugar is attached to the albumin level. So this gives a control over 2 to 3 weeks. But if you have hypoproteinemic states, then also it is falsely low, right? So the next case, is a 15-year-old young girl who came with polyuria, polydipsia, osmotic symptoms with some weight loss. She has high fasting blood sugar, HbA1c, so the diagnosis of diabetes is done. And then when a young child comes into, so this is 15-year-old, 13, 12-year-old, when a young child comes to your channeling or to see you, you get a bit panic, because you are wondering whether this child will have type 1 type of diabetes, where she will or he will have to be on lifelong insulin. So now going on further, what are the other important things we need to ask in the history? So one important thing is family history. So in this girl, there was a positive family history. Her mother and maternal relatives were involved. And in addition to that, cycles are important. So when a young person comes with diabetes, family history is very important. When in the history, use of steroids, and whether there are any other features of other endocrinopathies like Cushing's or polycystic ovarian syndrome, where there's insulin resistance and high sugar. So those things are important in the history. When you examine the patient, it's very important to find out whether there is acanthosis or not. So in this child, you can see the child is not having a high BMI, but sometimes they might not be having a high BMI. It's the acanthosis which is very important. So acanthosis you need to check in these people. So what is acanthosis? Acanthosis is velvety, blackish discoloration of the skin in the flexure area. So you can see in the back of the neck, nape of the neck, and then in the knuckles, and then also in the flexor areas, the elbows and the groins and axilla, they will say they are really black color. In addition to that, acanthosis affects the face. So you can see in this picture, the face is affected in the cheek area, forehead, around eyes, around mouth. So some people come to you and tell, I got discolored, I got pigmented. So actually, this is a form of pigmentation in insulin resistance. When you talk about, addisons, things like other causes of pigmentation is addisons. So knuckles will also get pigmented in addisons, but it's not like velvety. But they then how to differentiate is mainly by the buccal pigmentation in cases of it. So this patient was diagnosed with maturity onset diabetes. So, okay, what are the diagnostic criteria? So the onset of before the age of 25 years, presence of diabetes in 2 consecutive family generations. So that means the first degree relatives and beyond that, so the grandparents being affected. And then the blood test is absent of B cell autoantibodies, or the autoantibodies related to the type 1 disease, and the level of the C-peptide. Now, what is C-peptide? C-peptide is something, a molecule which is co-secreted with insulin. It has a longer half-life than insulin. So we use C-peptide to measure the level of insulin in the body. So higher C-peptide, so if it is less than 0.2 nanomoles per liter, it's taken as absolute insulin deficiency, like in type 1 diabetes. So in maturity onset diabetes, there is reduction. This is a autosomal dominant condition where there is reduction of insulin secretion, but it's not as bad as in type 1 diabetes. So there is reduction, but it's not as bad as the type 1 diabetes. So C-peptide is not very low. The definite mode of the diagnosis is genetics, which is not freely available to a country like us. Okay, so there are different types of diabetes, the most common being the type 1 diabetes. Most of the patients that we see is type 1. And then you have that, type 2. So most of the patients that we see is type 2. Out of our patients, about 5 to 7% of the patients will be type 1 diabetes. Then you have this maturity onset diabetes. And what is this LADA? LADA is latent autoimmune diabetes of adults. So this is a type of diabetes which occur in people who are more than 35 years. So they are okay with the oral drugs. At first, they respond to the oral drugs, but after 1 year, so after being on treatment for 6 months to 1 year, they rapidly lose control. And then you notice that however you try, the sugars are not controlled. So then actually they become insulin dependent. So when you check their blood sugar, the auto antibody levels for type 1, the antibodies are there, and the C-peptide is very low. Okay, so those are the things about diagnosis of diabetes in a young person. So the next question, more practical case scenario for us. A 55-year-old lady with type 2 diabetes. She had been on insulin oral drugs, and for the last 5 years she's only on insulin. She has impaired renal functions. The blood sugar is uncontrolled on mixed start insulin high dose, and her fasting blood sugar, HbA1c, everything is very high. So in addition to this, she also gets early morning hypoglycemia, complicating matters further. So this is a lady, she's not very obese. Her BMI is 22.8. She doesn't have features of Cushing's or acromegaly. Right, so it is very important to find the compliance. So this is a common scenario where patients come with uncontrolled diabetes. So if you take the first part, if you forget about this hypoglycemia on and off, most of our patients are having uncontrolled sugars. And the reason most of the time is due to lack of compliance to the drugs, because some of them don't take drugs because they think drugs will cause renal failure. Some of them don't take drugs because they are busy or something. They think, my kidney will fail. So like that, they don't take the drug. So compliance to drug is very, very important. So that's why it is important to check your HbA1c, because sometimes if you check the fasting blood sugar or the postprandial sugar, I think most of us
most of the time I have seen patients being checked the fasting blood sugar. So I remember when I was a senior registrar in National Hospital, there was one lady who was coming to her blood sugar levels to be done in the hospital, and she fainted in the train because of a hypoglycemic attack, because she has taken Tebu the day before, because when we asked, she said, if I have high sugars, the doctors will scold me. So I took this Tebu, and then she got a hypoglycemic attack and she fainted, like she lost consciousness in the train. So a lot of people do this type of thing. They either drink something, herbal substance, or then they get, because the doctors will scold them, they will do something for the last few days to reduce their sugar levels. But HbA1c is very, very important. So that is one thing I want to highlight to you all, to all that who are listening. So one problem with HbA1c is the cost. It's more costly than the other tests, but I think it's very important that we check that also. Okay, so so the drug compliance, diet compliance. So we know as South Asians, as Sri Lankans, we love our rice. So we eat a lot of rice. So that is how these patients, so I had one patient who was not controlled, who was not getting control at all. And when I asked, every day I tell about the diet, and then he says, yes, I'm complying. One day his son came and said, this guy is eating kitul hakuru, 1 kilo of kitul hakuru for a week, and he thinks kitul hakuru is good for the diabetes. So these are the things our society is thinking. So we need to tell our patients, anything which is sweet, except for the artificial sweetness, will have, most of them, what I say is, will have sugar. There may be exceptions, but for your patients, you can tell that if it is sweet, it has sugar. Then the other thing is starchy food, which we need to reduce compared to rice. So bread and all will have a very high increase in the sugar. So you need to stop them, kurakang, and these legumes and pulses we need to encourage. The other thing is fruits. So the other thing, our people love bananas, so bananas and pepper. That also we need to address. So you need to see the compliance with the drug. So the three things affect the blood sugar level. It's actually whether you are taking drugs, whether you are taking the diet properly. The third one is exercise. But then if you see all of these being controlled, still your blood sugar is high, then you need to address the other things, the psychological factors. So I had one patient who's, most of the time the doctors call the patient and the patient goes away. But sometimes depression and psychological stress due to various social problems is the underlying cause for high sugar. So you need to address that. Just don't call the patient and send. You need to ask them what is happening, how did you eat. So it will take time for your consultation, but it's a very good thing to do. Okay, so then insulin transport is important. I will deal on how to do these things. Insulin storage, who's injecting, how much, where, all these things. I had one patient who was injecting insulin for a long time to the calf, which is quite wrong. I'll show you where we should inject insulin. Okay, so in this patient, the issue was the injection of insulin. So this patient has had features of lipoatrophy in her arm where the injections were given. So how did we manage? We have to avoid the site of lipoatrophy. So I will tell you in later slides how insulin works. So insulin should be given to the fat tissue, fat layer, the subcutaneous fat area. So when you give insulin for the subcutaneous tissue for a long time, you can get these lipodystrophic reactions. And then when you give this to that area which is scarred, the insulin absorption doesn't happen properly. So the sugars will get erratic. So we need to avoid the sites of lipoatrophy, as well as we need to correct the injection technique. So why would someone develop lipoatrophy? So these are the reasons for someone to develop lipoatrophy. In the old days where human insulin were not there and analogs were not there, especially with the animal insulins were used, lipodystrophies were very common, and it was regarded as an immune reaction to the insulin. In addition to that, any other subcutaneous injection, the other subcutaneous injections can long-term, when you give, they can also cause lipoatrophy. So using of a blunt needle, repeated injection of the same site are the causes for dystrophy. So in this patient, we told her to avoid that area. We have to correct her technique because she was using the same needle. And the other thing is using pure insulins, like insulin analogs are better. Or okay. So right. So what are the causes of apparent resistance? So as we mentioned, it may be due to the inappropriate technique of using the insulin, or the other things like, the diet, of course, lack of exercise. And then the other factors which increase the insulin requirement is intercurrent infection. So if your patient is having nice sugar level, and then suddenly the sugar rises, you need to look for the patient comes to you and එකපාරටම doctor මගේ සීනි වැඩි වුණා ඒ නිසායි මං ආවේ. එතකොට you need to look for cellulitis. These people may have intratigo in between toes, fungal infections causing cellulitis. So all those things, or UTI. So when someone is having a good patient who's listening to you having suddenly high sugar level, it may be infection which is the cause. Okay. So right, so I'm going to the next case, which is a 60-year-old male with type 2 diabetes on premix insulin presenting with early morning hypoglycemia. This is again a common scenario. So this is the thing. So you have these insulins, which I will deal in the later slides. But what we commonly give in our hospital is called the premix insulin. Now, this nomenclature is also very important because we used to call it mixed-tard insulin. So that's how we name mixed-tard insulin all the time. But mixed-tard is actually a trade name used for this Novo Nordisk company, premix insulin. So when you basically give this premix insulin, you can see in this graph. Now these healthy people, which is shown in this black color, these bars, their insulin levels are shown in this later graph. And then when you give NPH, it is shown in that dotted line. So you can see in the patient, when the patient is having, so the time is given from 8 a.m. to the next day 8 a.m. By the midnight or early morning, the insulin levels are higher. If you look at this red bar, you can see in a normal non-diabetic person insulin level compared to the NPH insulin level, there's a very high level. So this is why they get hypoglycemia in the early morning. So hypoglycemia is quite common around 2 a.m., 3 a.m. in this type of patients. So what can you do? You can reduce the night dose. You can correct the timing of injection. So timing of injection is very important because soluble or this premix insulin should be given 30 minutes prior to their meal. Sometimes a lot of people are doing mistakes in this. They just inject the insulin, then they eat. So unless you are taking analog, if you are taking the usual human premix insulin, you need to inject it 30 minutes before. So the other thing is you can use analogs, and then you can move into any other regime called the basal bolus regime, where you can take off the NPH, because we know the NPH, or what is NPH? NPH is the basal insulin. So the premix insulin is made out of two groups of insulin, the soluble, which is rapid acting to cover the meals, and the basal insulin, which is the NPH. So you can move it towards the bedtime. And then some of our patients, they get hypoglycemia due to herbal substances, like the patient I told you. They may be having GI issues like gastroparesis. And the other important thing, some of these patients are on sulfonylureas. Now, should you stop sulfonylureas when someone is started on insulin? There is controversy in this area. So all guidelines said, yes, you need to stop sulfonylureas when you start insulin. But they found that when you stop sulfonylureas, the requirement for your insulin is very high. You need very high doses. So for some patients, when it's difficult to control their sugar, we use sulfonylureas. But these patients on sulfonylureas are prone to get this nocturnal hypoglycemia. The other way is to check a sugar level before they go into the bed. They go to bed, they can have a snack, particularly if their sugar level is less than 6.5. And alcohol is another cause to get hypoglycemia, because high levels of alcohol impairs the liver glucose excretion to the blood. Liver sends glucose to the blood. So this is inhibited by high level of alcohol. So the important thing is, so this is the aim of, this is a normal person, not a diabetic person. This is the level of insulin. So you can see there are 3 peaks. With each meal, they get rise in the level of the insulin level, and but at the basal level, insulin level is not 0. It is, so that is why we give a basal insulin, and then to cover the meals, we give a short acting insulin. Okay, so this is the development of insulin. Now in this year, we it was 100 years of insulin was celebrated. Actually, in old days when type 1 diabetic patients were diagnosed, the ultimate diagnosis mean like, they are going to die. But with this finding of insulin, they got a new life. So over time, insulins were developed. So first we got insulin from animal preparations, then the development of human insulins came, and then the analog insulins came. So what do you mean by human insulin and analog? So previously insulins were taken from animals, and then these caused so many impurities, so causing reactions, allergies and all, the lipodystrophy and all. So people took this insulin, the genome, and inject into the E. coli and make the E. coli produce insulin. So human genome was taken, injected to the E. coli, and now that is called the recombinant methods of producing insulin. So that is how human insulin is produced now. Right. So what is the difference of human insulin and analog insulin? So I think sometimes we get confused with these names. Now, human insulin is having the same an amino acid sequence as a normal one which is found in our body. But if you change this amino acid 1 or 2, then you can change the pharmacokinetic properties of the insulin. So previously we had only the human insulin, which had the same amino acid sequence. To make it last longer or shorter, particularly to make it last longer, people used to add various molecules like zinc and protein. So one insulin like that is lente insulin, where they added zinc to the normal human insulin to make it last longer, to make an intermediate insulin. So NPH insulin is also something like that. But later on, in 1990s, analogs were started on. So analogs have different amino acid sequence than the usual human insulin level. Okay, so these are the types of insulin. I think this is interesting. So you have the rapid acting insulin, you have the regular short acting insulin, which are given as boluses. You can see that compared to the rapid acting insulin, the action of rapid acting insulin by about 4 hours, it's over. But if you take regular insulin, sometimes it lasts for even 8 hours, even though this graph ends at about 5 hours, it lasts for about 8 hours. Then the intermediate acting insulin, and then the long acting. So these are the types of insulin that we have at the moment. So these are the names of the, I think it will be practical. This is practical knowledge, because sometimes you say one name and then you are confused what it is. Now, one thing I want to tell you is, always in the BHT we write lente insulin, lente. Actually, lente is not produced now. The Lilly company which produced lente stopped producing lente now, because lente could not make NPH is used to make the premix insulins. By adding 70% of NPH to the soluble insulin, you can make the premix insulin, which we call the mixed start. But lente, they found lente cannot be you can't make premix insulins with lente, because the soluble, when you put soluble with the lente, soluble loses its efficiency as a the short acting insulin. So with all of that, I think lente disappeared from the market, and then they discontinued, telling that there are never better agents available. So the soluble insulin, the commercially available one, if someone says atropine humulin R, so R is for the regular, then N is for the NPH, the intermediate acting one, and then the rapid, so the analog. So the human insulins, we have only short acting and the intermediate acting. The rapid acting ones are analogs, because so you have the human log which is from the Lilly company. Then you have the Aspart by the Novo, Glulicine from Sanofi. So all these companies are there, and these are available in our hospital. Then in our in our practice, the very fast acting insulin called the Fiasp, which is very fast. Even you can inject it after meals. So, and then you have this inhaled insulin. Inhaled insulin is not still not very well, doing very well actually, because of the lung side effects it is causing. But they are very rapidly acting. Then you have the long acting insulins, Glargine, Detima, and Degludec. Okay, so this is the other thing I wanted to highlight. The rapid acting peak is the peak lasts for 2 hours, and the action will be over by 4 hours. But if you take the short acting insulin, it will last for up to 8 hours. The peak up to 4 hours, there will be a peak. So that is why that guy who had the mixed insulin, who got the nocturnal hypoglycemia, his the long acting as well as the soluble insulin, both are acting by about 5 hours. If he injects about 8 p.m., by about 2 or 3 a.m., both are acting at peaks. So, I mean, the basal insulin is not actually giving a peak, but soluble insulin is giving a peak, causing a hypoglycemia. Right. So, now, why should we inject insulin 30 minutes before the meal is shown by this. So you can see in this lower picture that insulin is injected to the subcutaneous tissue and to the fat, should be injected to the fat. And insulin appears in groups of 6s. One by one, it is broken. This process takes, so it's broken into several folds, and then finally becomes monomeric, and only the monomeric form is absorbed. So that is why it takes about 30 minutes to be absorbed. Okay, so what are the insulin regimes? So actually the ADA and most of the guidelines talk about, you have these oral drugs and start basal. So usually the recommended dose is, if your patient is not responding to the oral drugs, you start a basal insulin, or else you can even start a premix insulin. Right, so this is called the BIDS regime. That is the basal insulin daytime sulfonylurea regime, where you continue your drugs, but then you give only a nighttime insulin. This is to control your fasting blood sugar. So if you find that your postprandial sugars are also high, you may give premix insulin. And then basal plus means, in a patient who's maintaining a log or SMBG, you can see, this patient is before lunch, the sugar is okay. Post lunch, the sugar is very high. Then you can give only for the lunch time. So you can give basal plus means 1 meal time rapid acting insulin, or you can give basal insulin for several meals. Basal insulin plus rapid acting insulin to cover several meals also. So to find this, first we need to know our targets. So the target fasting blood sugar and the pre-meal sugar is about 80 to 126 according to the ADA, American Diabetic Association. So the target postprandial sugar is 180 or low. So if you have a high fasting blood sugar, if you have only, now in this patient, if this case, you can see the fasting blood sugar is 232. The post-breakfast, the post-lunch, they are all like fluctuating. But you can see, like, if you get the fasting blood sugar down, all the others will come down. So this is a candidate for the basal insulin. Okay, so the other important thing is, if the fasting blood sugar is low, there is something called the Somagi effect, or can you remember those things in the medical school you learned? So if the fasting blood sugar is high, it can be due to 2 reasons. The lack of basal insulin or hypoglycemia in the early morning, causing our, the stress system to get activated. The cortisol will increase and try to increase the sugar. By morning, the sugars will be high. So if someone is having high sugar, particularly if the patient is on insulin, you need to check the morning 2 or 3 a.m. sugar is very important in this people. So you have this dawn phenomenon and the Somagi effect. Somagi effect is when it's depicted in the red line, where you have low dip in the sugar, causing the body's reactive mechanisms to counteract this low sugar and increase sugar. Dawn phenomenon is anyway you have a cortisol increase in the morning, so you have a higher sugar in the morning. Right, so this we discussed. So the basal insulins are NPH, Lente, or the newer analogs are also there, as we mentioned. So, so in our college, the Sri Lanka College of Endocrinologists and the ADA and the international societies also mentioned the preferable regime may be the basal insulin. As we know, the fasting blood sugar is controlled with this basal insulin. It is the main. So you can see, like, if you remember the first slides that I showed you, the fasting blood sugar, when your HbA1c is very high, when you control your fasting blood sugar, rapidly the HbA1c will come down. Now, but the most important thing, I think, practically, so many would ask what is the starting dose. So it's always good to start at a low dose because we don't want them to get hypoglycemic. So the starting dose is 0.1 to 0.2. But if you have higher sugars, you may even give a higher dose like 0.3 to 0.4. Okay, so when to give the premix insulin or mixed start. So you can see if the fasting blood sugar is normal, the postprandial sugar is above the target, the HbA1c is elevated despite the fasting blood sugar being normal. And the other thing is basal insulin level being very high. So studies have shown that the basal insulin, particularly this one study showing glargine, if the glargine level is more than 0.5 units per kg, by increasing the dose further, the reduction is not very good. The blood sugar reduction is not very good. So the starting dose of premix insulin, usually we start with a lower dose, then we can adjust. So dose would be 0.3 to 0.5. So for basal insulin, it will be like about 0.1 to 0.2. If you are starting a premix insulin, you start on 0.3 to 0.5 like. Sometimes you may need more than that. So you give 2/3 in the morning and 1/3 in the evening, covering the evening meal. Okay, so this patient, it's another scenario where you can see now, if you look at his blood sugars, the pre-breakfast, the morning is good, the pre-lunch is good, post-lunch is not measured, pre-supper is high, and the post-supper is high. So if you look at the pre-supper and post-supper, you can see that both are high, but even pre-supper is even above the post-supper. So by controlling the pre-supper, you can reduce the post-supper also. So, so this patient was only on basal NPH in the night time, bedtime NPH. Sometimes NPH lasts for 12 hours, unlike the newer analogs, which last for 24 hours. So in that case, we have to control the pre-dinner sugar by giving a morning NPH, or else the patient might be having a large snack in the in the tea time. So you need to adjust that. You need to get the history from the patient, what the patient is taking. If the patient is having a adequate not like a small snack, then you have to add morning NPH, or even you can change to the premix insulins. Okay, so the other important thing about this nomenclature, because sometimes you get confused. So in the hospital, we give insulin vials, which have 1,000 units of insulin. Then you have cartridges, which we use for pen devices. It has 300 units of insulin. Okay, so what is this U100, U200, and all these things? So usual insulin that is available in our country, the 1 ml of insulin has 100 units of insulin. So if you take 1 ml of insulin, you have 100 units of insulin. That is called U100. So that is the insulin that we use in day-to-day life these days. But in other countries, U200, U300, U500 is also available. So that means for 1 ml, you have either 200 units or 300 units or 500 units of insulin. So this is particularly useful when the patient requires high amounts of insulin, because if you are taking U100, then you have to inject a large dose. So when you give a large dose to this subcutaneous tissue of yours, the insulin, the absorption gets affected. So insulin action gets delayed, and the prolonged duration can happen. So you can get nocturnal hypoglycemias. So that's why, so that is what happens when you give a large dose of insulin. So when you give this concentrated insulin, they found in studies that there was less variability of the blood sugar, less weight gain, as well as less nocturnal hypoglycemia. The other important thing is when you give insulin, if your patient is on a large dose, for example, 6 units in the morning, you need to split it. You can't give the whole 60 at the same time. That affects the HbA1c and the absorption. So they found that if you split the insulin to 2, if it is equal or more than 60 units, then you get a better outcome. Okay, so how do you inject? So the needle that we have is most of the time we have the 6 millimeter needle. For thin patients, even 4 millimeter is fine. So this picture shows you that if it's better to use the shortest needle available. So in our market and with the insulin needle, we have in the insulin syringe, we have the 6 millimeter needle. If it is about 8, it can touch your muscle. So what happens if it touches the muscle, you can get a rapid response, you can get hypoglycemia. So particularly when, so we know that insulin should be injected to the fat tissue. So in patients who are particularly very thin, emaciated, or patients with pancreatitis and all, so when they have very low fat tissue, you may have to pinch your skin. The correct way to pinch is shown. You have to only use your index finger and the thumb. You shouldn't use your whole hand. If you use your whole hand, the muscle also comes up. So in these very thin patients, better to use the abdomen as a site, because that has the highest level of fat. So the site of insulin injection, as I told you, I think there was one patient injecting to the calf. So here we are targeting, because we are giving this insulin into the fat tissue. From the fat tissue only, these hexamers get broken, and then you get monomers absorbed, as I showed you in that picture. So we need to inject to places where there is fat. You shouldn't inject to muscles. So, so these are the areas, but the important thing is you need to rotate the sites. Transport of insulin is very important. You shouldn't transport with direct contact of ice. It shouldn't touch the ice. So this is one picture. You can see that there is ice cubes on the side with a layer of cotton covering, so that the ice is not touching directly the insulin the cartridges or vials. Even the pen, it is the same. And the other thing is, when you transport, you should not keep it in a hot car. So we know that you can keep, once you put the pen, it is, once you put the cartridge into the pen, you can keep this insulin at 30 degrees for 1 month. So in the room temperature, we can keep it even outside, but it shouldn't get heated more than that. Okay, so this is the fridge. So when you ask from your patients, you should ask, where do you keep your fridge? This is from the IDF. They have mentioned, now they have checked the sugar, the levels of temperature in the fridge. So you can see that recommended temperature is in this 36 to 46 Fahrenheit, in that range. So if you look at the door, the blue line, it is more hot than that. If you, now here in this fridge, most of our fridge have the freezer on top. In this fridge, the freezer is in the down area. So if you have, the area which is close to the freezer gets sometimes gets too cold. So it is recommended to avoid that area, to use the compartment. Just keep the insulin in an airtight compartment away from the freezer, as well as don't keep it in the door also. So this other thing is an interesting thing, a patient developing allergic reaction to insulin. I think in your practice, you might have seen few patients with this type of reaction. These reactions are due to zinc. Most of the time they are due to zinc, which is used in these insulin preparations. And so in these patients who develop these allergic reactions, sometimes we can use if we can change to oral drugs, or else if the sugars are very high, we can't control with oral drugs, then we need to give them some of them we can manage with soluble insulin, because it does have zinc a little bit, but not as much as the long acting insulins. But some people still, with this soluble insulin also, they develop this reaction. So in those patients, we can use the insulin analogs, because that doesn't have zinc. So what are the blood sugar targets? Coming into the next topic, so we actually mentioned, so the pre-meal fasting we try to maintain from 80 to 130. You can see that there's a big range, and then the post-meal is less than 180. But this is not for everyone. So, you know, it depends on the patient attitudes, the support the patient have, the risk of hypoglycemia, the disease duration, life expectancy, comorbidities. You have less stringent targets if you have all these comorbidities. But if it is a newly diagnosed patient, then you would try to achieve the best control possible. Motivated patient, best control possible. But always when you try to get the best control, you are at risk of developing hypoglycemias. Okay, so this is the target. So this is from our college, Endocrine Society College, Sri Lanka College of Endocrinologists. So you at least, you know, if your HbA1c is above 8, that means that means that's very bad. So at least you have to maintain it less than 8. So young onset, new, well motivated patients, you try to maintain 6.5 or low. Right, so these are the guidelines that were used. So some time back, the American Diabetic Association, you always start with, now previously when we were like, I think in the medical faculty days, like in lipid management, when someone is diagnosed with diabetes, we would say, okay, do the lifestyle modifications, and if it is not controlled, we'll start drugs. But then a study called UK-PDS showed that giving metformin reduced mortality in a group of patients. So that's why now, along with lifestyle modifications, we start metformin just when the patient is diagnosed. So if the person is not controlled with metformin monotherapy, then you need to add dual therapy and triple therapy. If your patient is having a very high sugar above 300, you may even start insulin at the beginning. Okay, so how low is the issue? So this slide is talking about how low we should target the HbA1c. So these are landmark studies. The DCCT study was done for type 1 diabetic patients, UK-PDS for type 2 diabetes. In these studies, they found that there was a significant reduction in microvascular complications when you have a very good control. Macrovascular complications at the studies, it was less robust, the macrovascular complications, but on long term they found that there is some degree of macrovascular complication reduction also. So then when they found this, they did other studies to find out, okay, if we try to reduce the HbA1c more and more, will we have better outcome? So this was studied in this Accord study. So you can see Accord study, maybe you might remember, it was stopped suddenly. It was stopped because it showed that there was a higher mortality in patients with who targeted a better HbA1c control. So if you look at this this graph, this is the standard therapy, and then you have this the intensive therapy. So you started at a HbA1c above 8, and then the standard therapy HbA1c suddenly dropped to 2 or more, around 6.5, but standard therapy about 7.5. They found that when you suddenly rapidly try to reduce this sugar level, the HbA1c level, they got higher mortality. Most of these deaths were cardiovascular deaths. They got arrhythmias and all. Okay, so they stopped this Accord study, and then they thought, what I showed you, we need to adjust according to the patient characteristics. So most of these patients in the Accord study were long-term diabetic patients. They had other cardiovascular problems like cardiovascular issues. So in that type of patients, we should not try to do the best. That is what the graphs show. Okay, so the latest guidelines are different. Now, as I mentioned, even the UK-PDS, DCCT studies, for the macrovascular outcome, they didn't have a very good response, even the sugar control. Now but newer classes of drugs have come which show a very good response to when it comes to cardiovascular benefits. So even the latest guidelines, first thing is lifestyle and metformin. The next thing is to find out whether this patient has established cardiovascular disease. The patient already diagnosed renal failure patient, or having a cardiovascular disease? If so, you need to give these drugs, which is SGLT2 inhibitors or GLP-1 receptor agonists. I'll go through them later. If the patient is not having established cardiovascular disease, then you can decide on the drug you are giving. So it depends on whether you want to avoid hypoglycemia, then you will not give sulfonylureas. If the weight reduction is a target, then you might give other drugs. If the cost is a major issue, then you can decide on the drug. So this is for now, this is the guideline in America. That's what they follow. So practically for our patient, it might be difficult because the SGLT2 inhibitors are not available in the hospital. GLP-1 analogs are very expensive. So practically for Sri Lanka, it may not be possible, but still we should, at least for the affordable people, we should try now these SGLT2 inhibitors. There are newer drugs which are like not very expensive SGLT2 inhibitors. There are commercially ones which are not very expensive. So we might use them, but for the hospital at the moment, we don't have these drugs in the hospital care setting. Right. So why did we crown metformin to be on top of all the algorithms? It is because of this UKPDS study where they found that all-cause mortality. This was actually in obese patients in the UKPDS study, that it reduces significantly all-cause mortality. Now, this finding was not replicated in some of the randomized, some other meta-analysis and all. This was not replicated, but still this was a very important finding. So metformin has been in the market for a long time, a long-term use drug. So still it's still having a crown. Okay, so metformin, again, now metformin is the drug that most of our patients are scared of. They say, "Hammo metformin nan denne epa, mage wakugadu narak veyi." So why do people say this? Actually speaking, I think as doctors, we need to get this out of our patients. So metformin, why can't we give in renal failure patients? Is because it's excreted via the kidney. So if someone is having a low GFR, then it's not excreted, so it gets accumulated in the body, and complications like lactic acidosis can occur. Right, so that's why we just stop metformin when there is renal impairment. So previous guidelines in around 1995, the guidelines say, okay, stop metformin when the creatinine is above 1.5 for men, because they have a higher muscle mass compared to women, which is 1.4. But then when they actually looked at the cases, lactic acidosis was extremely rare. So the FDA changed this, in 2016, long time back. 2016, they changed this thing, and then this new recommendation came. If the eGFR is less than 30, you stop it. But if it is between 30 to 45, you can continue, but you don't give the full dose, which is 1 gram 3 times a day. You give a lower dose, half of it is the recommended dose. So does metformin cause kidney damage? Actually, no. In this animal study, they found that the mice were given this nephrotoxic drug adenine, and some of them were given metformin. They found that metformin actually was renoprotective. It inhibited the interstitial fibrosis, which is a main thing in chronic kidney disease. So it inhibited the interstitial fibrosis and also albuminuria. So it may be actually kidney protective in the early stages. So please tell this to your patient. Whenever you tell your patient, some patients come to me and tell, I really need to check my kidney because I was on metformin for a long time. So you need to tell your patient, give this message: metformin does not cause renal failure. It may be even renoprotective, but these studies were not done in humans, they were done in animals. So these new drugs, which we discussed in the algorithm, are coming, they have cardiovascular benefits, they reduce heart failure, they reduce the progression of CKD, and they are the SGLT2 inhibitors and GLP-1 analogs. Okay, what are SGLT2 inhibitors? Now we have our kidney. So in physiology, we study that we have the glomerulus, and everything gets, gets into the glomerulus. And in the proximal tubule, most of the thing, 90% of everything is reabsorbed. So is sugar. So you get the glucose into your glomerulus, and 90% of this glucose is absorbed in the proximal convoluted tubule, And this is via the channel of SGLT2. So what we do is actually block this channel so that the glucose is not absorbed, glucose is going out from your tubule, going out with the urine. So that is the mechanism of using this SGLT2 inhibitors. What about incretins? Now, this incretin is another interesting molecule. So, you know, this you might remember, I don't know if you know this, when they found, now people were given oral glucose load, the same amount of insulin, same amount of glucose was given IV, intravenously and orally. And then they checked the insulin level produced. So if you look at the IV, the red line, the insulin level produced by the IV is not very high, but the ones given orally, they had a very high level of insulin. So, so this is the incretin. So that is how this interesting molecule called incretins were discovered. So incretins are the GLP-1, incretin is GLP-1. GLP-1 will stimulate the insulin secretion and then it suppresses the glucagon secretion. Now, GLP-1 is it's having a very short half-life, so we can't give the natural GLP-1. What we give is analogs, which have a longer half-life. GLP-1 is broken down by this enzyme called the DPP-4 inhibitors, and the common drugs that we use, the sitagliptin, linagliptin, they act here by blocking the DPP-4 enzyme. Okay, so these are the studies. So basically, all these, so this is about the SGLT2 inhibitors. All these studies, when it comes to renal and cardiovascular outcome, there was a significant reduction in the, you know, the worst scenarios. So the cardiovascular non-fatal death, MI, was significantly reduced. Renal outcome, you know, the doubling of the creatinine, worsening of creatinine was less when you use the SGLT2 inhibitors. And now another important thing is, I have showed here the DAPA-CKD study, which was released recently, where they have used the dapagliflozin, which is, so these are the SGLT2 inhibitors, the empagliflozin, dapagliflozin, canagliflozin. So in Sri Lanka we have the dapagliflozin and empagliflozin. Canagliflozin they wanted to start, but somehow I think they are still not, it's not still in the market. So dapagliflozin was used in the DAPA-CKD study because these drugs have a good renal outcome. The DAPA-CKD, they tried this drug on non-diabetic patients also. So if you look at the baseline, only 68% was having diabetes, the rest were not diabetic, and they found that it was it didn't cause hypoglycemia. So when we give a diabetic drug to non-diabetic people, what we are worried of is whether it can cause hypoglycemia, but it didn't cause hypoglycemia. And the other interesting thing is the eGFR of this group of patients is from 25 to 75. At the moment, the international guidelines have not mentioned a very low GFR as a possibility to give these SGLT2 inhibitors, but in these studies, they have used patients with very low GFR and they also benefited. So, so they found this overall outcome, GFR decline by 50%, cardiovascular death. So if you look at this chart, you can see dapagliflozin is better in patients who were given dapagliflozin. The secondary outcomes, all-cause mortality, were significantly lower in people who were given dapagliflozin. Okay, so the same thing happened in the DAPA heart failure study. They used people who have heart failure without having diabetes, and that also improved the outcomes. Okay, so renal dosing at the moment, the guidelines have, even though the studies are using people who have a lower GFR, the renal dosing of SGLT2 inhibitors, these are the things. So if it is less than 30, we don't actually give according to the guidelines, but actually studies have given, and for some patients we do give because the studies have. Now what happens if the GFR is low is that they will not have a very good sugar reduction. but the renal protection, the reduction in heart failure is there. They might not have a very good, very low sugar control with usage of low GFR, but there are no side effects. So that's why these are used in these studies. So what are the disadvantages? So weight loss is one major disadvantage, and then candidiasis is one thing. So recurrent UTI is one problem with the SGLT2 inhibitors. And the other thing is they can get dehydrated if they don't take enough, because these SGLT2 inhibitors have a diuretic effect, because the sugar is going out from the kidney, water is also going out, and that is so with that, if you don't drink enough water, you can get dehydrated and they can develop ketoacidosis. This is called euglycemic ketoacidosis, where their blood sugars are not very high, but they are dehydrated and ketone bodies will be there. Then if they don't drink enough water, they can get into acute kidney injury. Even though in long term they are protective to the kidney, acute kidney injury can occur in the short term. Then genital mycotic infection. So actually these mycotic fungal infections, they respond very well to antifungal drugs. So this is not actually a reason to stop this drug unless the patient finds it very difficult. So you may give the patient's antifungal treatment, but then if it is very hard for the patient, then you may stop. In males particularly, it may be good to stop it if the antifungal infections are not responding. If the patient is developing recurrent UTI, okay, then we really need to stop the SGLT2 inhibitor. So I have seen patients managed by some doctors who gets recurrent UTI. You are treating the UTI, the patient is on SGLT2 inhibitor, they are not stopping it. So there are other minor side effects which are not very important. So the importance of SGLT2 inhibitors, it has a HbA1c reduction, the hypoglycemia risk is very low, even in non-diabetic patients it has been used. It has a blood pressure lowering effect, and then weight loss, and then the cardiovascular benefits have been shown for all these studies, by all these studies. So this is about the GLP-1 analogs which we mentioned. So particularly the leader study, which is liraglutide. So in Sri Lanka, we have liraglutide called the Victoza. So they found that liraglutide had, when it came to particularly liraglutide, primary composite cardiovascular endpoints, cardiovascular death, everything, there was a significant reduction. And similarly, other drugs also had non-inferiority or significant reduction on the cardiovascular outcomes. Similarly, for the renal outcomes also, these drugs have benefit for reducing the macroalbuminuria, doubling of creatinine, need for renal replacement therapy. So that's why they have come up in the guidelines. Okay, so then without touching this area, I think it's not good to finish this presentation regarding the cardiovascular risk reduction in diabetes. So we know that diabetes has a high chance of, patients with diabetes have a high chance of developing cardiovascular disease. We said it's about 4 times. And so we need to address this, like we are addressing it in the pre-diabetes, even more so, we need to address the cardiovascular issues in a diabetic patient also. So when you have diabetes, you are 3 to 4 times higher risk of developing heart issues and strokes. So you have to maintain the tips, being active, stopping smoking, making healthy food choices, trying to lose weight is all important. And then there are other drugs we use. So what about the lipid drugs? Okay, so this is very important for us. So now the American Diabetic Association and the American Association of Clinical Endocrinologists are slightly telling different things when it comes to here, because the American Diabetic Association is talking about the degree of reduction from the point of LDL at the baseline to degree of reduction, and the AACE is talking about the LDL goal. I think we should, it is also important to remember. So LDL goal is also important. So if someone is having if someone is more than 40 years, the patient is having already diagnosed cardiovascular disease, then your LDL goal is less than 55, you have to give high intensity statins. So if you have one or more ACVD, ACVD means atherosclerotic cardiovascular disease risk factors. If you have one or more, like hypertension or whatever, proteinuria, family history, if you have one or more, then your again the ADA says you have to give high intensity statins, but the AACE has lessened the LDL target to less than 70. Now, if there are no ACVD risk factors, you just have diabetes, the LDL target is less than 100. In that case, you give moderate intensity statin. So this is for more than 40-year-olds. So less than 40-year-olds, you give statins. Moderate intensity or high intensity statins is what the ADA is mentioning. If you have one of these cardiovascular risk factors, the LDL level more than 100, the high blood pressure, presence patient is smoking, there is CKD or albuminuria, if there is positive family history of atherosclerotic cardiovascular disease. So if what is positive family history? In the first degree relative, male having a cardiovascular event less than 50 years, or a female having a cardiovascular event more than 60 years of age. So this is the intensity things we were talking about. The moderate intensity statin means atorvastatin 10 to 20, high intensity means atorvastatin 40 to 80. So it's sometimes very hard for our patients to tolerate high doses of statin because they get muscle pains, and also their liver enzymes can get elevated. So in that case, we can use ezetimibe. Ezetimibe is a drug we can use. It acts on the gut. It doesn't have systemic side effects. So ezetimibe can be used added on to the statins to reduce the LDL level. Now, what about using fibrates? Now, there are several studies done to assess whether fibrate addition to statin reduces the cardiovascular outcome, but that was negative. But if your patient's fibrate level is very high, above 5, so if your patient's triglyceride level is very high, above 500, then to prevent pancreatitis, you need to give the fibrates. But if it is not like that, at the moment, the American Diabetic Association, the indication to combine a fibrate is if your triglycerides are 200 with a HDL of less than 35. So low HDL means it is a cardiovascular risk factor. Combined with low HDL, if you have a high triglyceride, at that time you can combine a fibrate and a statin. So we don't give gemfibrozil for these patients. Only fenofibrate can be added because of the risk of muscle enzyme CPK elevation, rhabdomyolysis. Okay, so the blood pressure target is less than 140 to 90. If the patient is having higher risk of cardiovascular disease, we have this ASCVD score. So if the cardiovascular risk scores are high, and if the patient is having albuminuria, you may even target for a lower blood pressure level, unless the patient should not have treatment burden like dizziness and all. If the patient is developing, we need to relax our targets. What about aspirin therapy? So now previously aspirin was the mainstay for patients to prevent cardiovascular disease, but then the later studies found that there is no major benefit, as well as there is an increased risk of bleeding. So at the moment, what the guidelines say is, if someone is above 50 years and they have at least one additional major risk factor, you may give aspirin. So like family history, hypertension, smoking. So that also so if someone is having, if someone is young and having multiple cardiovascular risk factors, then for them also you can give aspirin. So aspirin use in patients under 21 years is not recommended because of the Reye's syndrome. So the other thing is, the last case is pre-pregnancy. Pre-pregnancy counseling and all, it's a very important area. As general practitioners, we need to really address. When a woman is having diabetes, first thing you need to always ask is, are you going to have children? Because the drugs can affect the child. It should be a planned pregnancy, because high sugars at the time of conception can have gross fetal problems. So actually the organogenesis happens in the first up to the 5 to 8 weeks. So before that, the patient needs to control her sugar. So now this lady, I put a MCQ on this, a lady who's planning pregnancy, and then so several factors I wanted to discuss in this. So pre-pregnancy, we need to attain a good preconception HbA1c, which is less than 6.5. You can even target less than that. I mean, less than 6.5 is enough because of the risk of hypoglycemia. And so you need to look for any complications, because retinopathy and nephropathy will worsen during pregnancy. So if someone has, now in this case, I told about a young lady who is recently diagnosed with diabetes, should you still screen her for retinopathy and nephropathy? Yes, because as I told you at the very few slides, most of our type 2 diabetic patients are undiagnosed. So she may be having undiagnosed type 2 diabetes for some time before she was actually full-blown diabetic coming with osmotic symptoms. So switching to insulin, if oral drugs, so some drugs are not safe for pregnancy. So actually insulin is the best treatment for pregnancy, and so we may change to insulin. And folic acid is given. So the NICE guidelines mention 5 milligrams per day, the UK guidelines, starting 3 months before and continuing at least 12 weeks preconception. And then the American Diabetic Association, ADA guidelines tells about at least 400 micrograms. So then we have to stop the other toxic drugs like ACE inhibitors, statins, we need to stop. So always a patient who's having diabetes, a young lady, should have a planned pregnancy with removal of all these toxic drugs. Weight reduction is important. Screening for retinopathy and nephropathy is important, as I said. So the other thing I wanted to slightly mention is about the Gdm diagnosis. So in the mid-pregnancy, after 22 weeks of POA, we do the ones who don't have diabetes. This is the time where their insulin resistance increases, where their human placental lactogen, all these counteractive hormones are at a peak. So this is the time we start to check the GDM or gestational diabetes. And so we do the 75 gram OGTT. So, and then these are the targets. So the important thing of GDM is, so fasting blood sugar above 100, 1 hour more than 180 and 2 hour more than 140 is adapted in the Sri Lankan guidelines. Some ADA says 153 for the 2 hour thing. So there are slight differences, and these are the targets adapted in Sri Lanka. So even in if one value is exceeded, you diagnose GDM. Most of these GDM mothers can be diagnosed with lifestyle modification. So exercise for about 30 minutes and then diet. So most of them, about 70% of these GDM mothers can be managed by diet and lifestyle modifications. Some of them would need drugs. Okay, so what about giving metformin? So metformin is commonly given during pregnancy also. So there were several studies going on, the MIG study, MIG tofu study, all of that. They have found that patients, the mothers who were given metformin, their children at birth, they had a lower fat amount, but as they grew older, they got a higher the BMI increased, they became more fat. So at the moment, metformin can be given if it is hard for the patient. So we need, it's not only theory, we need to see practical aspect. If the patient finds hard to get insulin, metformin can be given to this patient. And but it's so the latest guideline says just avoid metformin if there is a risk of IUGR or if there is a risk of preeclampsia. But in that case, you need to give insulin. If not, you can give metformin, but the best drug is actually insulin. The other thing newly added to this ADA guideline is starting aspirin. So patients who are having chronic diabetes, they are advised to take aspirin to prevent preeclampsia. Taking aspirin will prevent preeclampsia. It started usually after third trimester, 12 weeks or 16 weeks POA, continue to 36 weeks of POA. It is known to reduce the incidence of preeclampsia in pregnant patients with chronic diabetes. So if you want to read more, these are the places to read. So you have the Standards of Medical Care Diabetes, American Diabetic Association guidelines. So every year they are renewing, and then they are putting new guidelines. And then you can also read Medscape. Medscape education, the e-medicine has very up-to-date things, presentations on the new drugs and all. So if you want to read more, you can read on this area. So thank you very much. I hope you gained something. So thank you very much for listening.
Thank you very much, madam, for that very insightful lecture. We have a few questions to go through from the audience. Question number 1 is, madam, if a patient has a fasting blood sugar of 300 and no ketonuria, do we need to give insulin to prevent ketoacidosis?
So it depends on the scenario. So if your patient is having 300, above 300 of blood sugar, then it's not a must to give insulin if the patient is not having ketoacidosis. You know, the ketoacidosis diagnosis is having a blood sugar of 250, or either having, so you have 3 things, and then if you have 2 out of them, you diagnose ketoacidosis. So having ketone bodies, having a high sugar, and having acidosis. So if your patient is not having that, there is not, you don't have to give insulin just for the sugar. But some studies say, now even the ADA has mentioned, giving insulin at the early stage will improve reduce the glucose toxicity faster. So some of the patients who are given insulin remit the diabetes. So in a patient who's newly diagnosed, you may give insulin. So if the patient is already a diagnosed patient, the patient you mentioned already diagnosed and having 300 sugar, then you can increase the drugs and see. So it's not so you need to always go to the 3 things I mentioned, the diet, the drugs, whether the patient took properly, and exercise, all those things you assess, and then you can modify your oral drugs. So it depends on the scenario, I suppose.
The next question, madam. Admission criteria to an ETU patient with high blood sugar without HHS or DKA?
I think it's a tricky question for me. So I think, ETU, well, ETU is the emergency treatment unit. So you manage patients with emergency, I suppose. So in diabetic emergencies are 3 types. We have 3 diabetic emergencies. So you have high diabetic ketoacidosis, then you have hypospholic non-ketotic coma. So if there is any other cause, like for example, if the patient got a MI, then the patient will be admitted for the ETU for that. But if those things are not there, I don't know. I don't know the answer for that. I don't think the patient needs ETU admission.
Madam, we discussed this question. They are asking for a clarification. Is there any difference in interpreting HbA1c in anemic patients?
Yeah, so that's what I mentioned. So there is an effect of anemia for the HbA1c, because it depends on the type of anemia. So if you have iron deficiency anemia, then your red cell turnover is low. When you have deficiency anemias, your red cells are not produced properly. Then you have a higher HbA1c. But if it is like thalassemia major or hemoglobinopathy, where there is red cell destruction, then in that case the HbA1c is falsely HbA1c is falsely low, because there is no time for the red cells to bind this sugar. Yeah, so definitely anemia will affect. So it depends on the degree of anemia. So in one study, actually, thalassemia minor patients, where there is mild anemia with a hemoglobin about around 10, there is no significant effect with the HbA1c. But if your hemoglobin is very low, maybe around 8, then that will affect your interpretation.
Next question, madam. Does the pre-diabetic patients need any treatment? And I think you discussed this also. What are the lifestyle modification strategies for them? And how frequently the investigations should be done for these pre-diabetic patients?
Yeah, so as we mentioned, now this DPP study, the Diabetic Prevention Program, that was the one quoted for a long time. And when when we tell patients to exercise, when someone is having diabetes, we ask them to exercise, and we tell them, we actually quote this DPP study because it is the one which used this 150-minute exercise for a week. So one question is, how would you treat them? Yeah, so when someone is having pre-diabetes, we have several objectives. One thing is prevent them getting progress to diabetes. So that is by lifestyle modifications, exercise, and trying to lose weight. At least 7% of weight reduction in the DPP study was found enough to significantly reduce this onset of diabetes. And then so some patients might benefit from metformin. Some patients will the lifestyle modifications will be enough. So then the other thing is, we need to address the micro and particularly the macrovascular complications. So we need to screen for modifiable cardiovascular risks, and then like smoking, lipid control, all those things we need to assess. So the frequency of monitoring, so that is a bit of a tricky area, because maybe about 3 monthly, because the HbA1c may be the best test to find out whether someone is progressing into the pre-diabetes progressing into diabetes. From the chart I showed you, most of the studies show that the postprandial sugar is the one which is increasing first than the fasting. But actually, when you look at patients, and in some studies, it's actually the fasting sugar. So HbA1c will address both. So HbA1c, you can do 3 monthly. So at 3 to 6 monthly, you need to be there is no guideline as such how frequently you should check. So at least 3 to 6 monthly will be a good option, I think.
Following up on that, madam, HbA1c costs more, but fasting blood sugar and PPBS is less costly for the patient. So which is better to follow up, fasting blood sugar alone or PPBS alone, or both?
So I think I told you about my patient who ate tebu cola and then had a hypoglycemic attack in the train. So most of our elderly population, the Achila and Ciela, have done this in the past, because they can go through the GPs by doing this. So we need to change it, because new things now, diabetes, the guidelines are changing rapidly. So cost is a problem, I understand, because Sri Lanka is becoming, I suppose, poorer and poorer. But we can't withhold the best treatment from the patient. So we need to decide. So if you ask me whether it's PPBS or fasting blood sugar, these can change, because if you are eating a lot and for few days you are dieting, then you will have a good fasting blood sugar or a PPBS. If you are eating very well and then you are not controlling your diet, you are not taking your drugs, for few days you are controlling or eating those tebu cola and all this herbal stuff, then you will have a good fasting blood sugar and PPBS. But you can't lie to your HbA1c, because it's monitoring the long-term control. So if you ask me, I would say, yes, the HbA1c is the best. But at least, so these patients, I mean, they have economical issues. So, you have to decide. I can't tell. I would say the best method would be the HbA1c.
Next question, madam. What is the best drug to reduce the HbA1c?
These drugs, the effect on the HbA1c depends on their risk of, the blood sugar lowering. So sulfonylureas, insulin will be the best drug to reduce the HbA1c drastically. Now these, but they and even sulfonylureas, they reduce the HbA1c rapidly. But the other drugs like metformin, the DPP4 inhibitors, then the SGLT2 inhibitors, they don't cause a large decrease in HbA1c because they are, and at the same time their hypoglycemia risk is also low. So I would say the drugs to reduce the HbA1c rapidly would be insulin and sulfonylureas. But remember, we don't want to reduce the HbA1c rapidly. Remember the Accord study, they had to stop the study prematurely because there was increase in mortality. So if someone is someone is really motivated, for example, a doctor getting diabetes, newly diagnosed, then you may target a very good control. But if this is a old lady who's having diabetes for a long time, just don't try to reduce the sugar very fast and rapidly.
Madam, they're also requesting to see the slide or for you to explain about pre-diabetes diagnosis again.
Oh, okay. All right. So I am sharing that slide. Explanation on this. So basically the fasting blood sugar above 100 from the American Diabetic Association, the WHO has taken the normal fasting blood sugar is less than 110, but the ADA tells fasting blood sugar normal is less than 100. So actually this is depending on the complications that they get. So the we stick to the ADA guidelines. The fasting blood sugar of above 100 to 125 is pre-diabetes. Then the post-meal or the OGTT, post-glucose challenge level is this. So most of us, if we check our blood sugars in the middle ages, we may be having pre-diabetes, I suppose.
Next question, madam, another follow-up. What about taking metformin by a pre-diabetic patient?
Yeah, so basically I discussed in this DPP study where they addressed that patients who were obese and age young than 45 years, if they were obese, age young less than 45 years, and then they are having history of GDM, that subgroup of patients had a similar response to the lifestyle modifications when it came to progression to diabetes. So in that type of patients, we can use metformin.
Next question is also something we discussed, madam. The rationale to start antiplatelets in diabetic mellitus patient. If so, what is to be started?
So actually aspirin is the drug that we give. So we discussed this. So it depends on their cardiovascular risk. So if someone is more than 50 years of age and you have one or more cardiovascular risk factors, which I shared in the slide, then you will give. If someone is less than 50 years, definitely less than 21 years, we wouldn't use aspirin. So the aspirin is the one which has been mentioned in all these studies, not clopidogrel.
Next question is, madam, can we give Dianil for a GDM mother?
Yeah, so when I started my SR training in endocrinology, glyburide or Dianil, Dianil was the one, or glibenclamide, which is also called glyburide, was used for GDM mothers. But at the moment, it is not. So there were some clinical studies which said that it has a good reduction in the blood sugar control. But later on, studies found that when you compare to the maternal level of this sulfonylurea, the child also has about 70%, 50 to 70% of the blood level of the mother. of these drugs. So it is actually at the moment not recommended to use sulfonylureas, even though in the past it was mentioned we could use. At the moment, it's not recommended.
Next question is, madam, does smoking and alcohol affect nephropathy?
Yeah, definitely. Smoking, definitely yes. Alcohol, I'm not sure because I didn't read on that. Smoking, definitely yes. Alcohol, probably.
There are multiple requests asking for an explanation of good fruits or a diet plan for diabetic patients.
So I think it's a tricky area. So what I do is I tell them, so when a patient with diabetes come to me, first thing I always tell is, I tell, why do patients with diabetes get problems? So I tell them your blood vessels get damaged because you have high sugars. When the sugars go through your blood vessels, I try to explain the vascular complications to them. So I tell them, okay, your high sugars go through your blood vessels, it damages your blood vessels. And then because of this damage, blood with time, blood will not flow properly to in your vessels. So if it doesn't flow to your brain, you will get a stroke. If it doesn't flow to your heart, you get a heart attack. Then the kidney, you get kidney problems. Then your eyes, you will get blindness, all of that. So that is the first step I do. Then, of course, I tell, okay, what is the target? So roughly I tell them the target, I go to the middle way, the ADA guideline has told 80 to 130 as the fasting sugar target, but I tell, okay, roughly fasting blood sugar, our target is less than 110 or like that, you can tell a target. So then I give them a target. So I tell them, okay, to prevent your blood vessels getting damaged, you need to target to have a blood sugar level of a non-diabetic person. So then your blood sugars, your blood vessels won't get affected. So that's what, it's not 100% sure, correct, but for the patient's understanding, I think that is a good explanation. So I tell them, okay, how do you control this sugar level? It's by 3 mechanisms. It's by taking your drugs properly, which is very important, controlling your diet, as important as taking the drugs, and exercise is an added benefit. Exercising will also help reduce your liver fat, fatty liver, and also it will help the lipid levels also, increasing the HDL. It will have protective heart effects on the heart also. So that I said. So next I go to the diet explanation. So first thing I tell is sweets. So as I told you, that Hakuru patient that I had who's eating 1 kilo of kitul hakuru, thinking that it's good for his diabetes. What they tell is, this is pure hakuru, not bad hakuru, not mixed with sugar. They are the good hakuru. So, but then you have to tell anything which is sweet, you need to avoid, because take a minimum amount. So that's what I tell first. So then I tell about the starchy food. So starchy food will be, first thing is the rice, and then you have this ala and all these manioka, ala, batala, all these things, and then you have the bread. So when you talk about rice can increase the sugar levels. So the type of rice, even though we were classically told that the type of rice doesn't affect, clinically practicing, I have noticed that people who eat samba and white rice, they have a higher HbA1c. But actually, theoretically, we were told that it actually doesn't have a major effect. So if they can increase the amount of pulses, and in the night, if they can, particularly if the patient is not on insulin, they can have a very light dinner, because the dinner is the one which is affecting the fasting sugar. So have a soup or kurakang is good. So eating vegetables with some proteins in the night, without eating rice, or indiap or string hoppers or rice, or roti in the night. So if you eat something like that, kurakang is okay. And then the white bread is the other culprit. So kurakampang, I have noticed, this is my practical experience, I'm telling you. I have noticed like kurakampang and all doesn't affect much. It doesn't increase the sugar. Then the other practical thing I have noticed is the fruits. So fruits is the other culprit. Now, For example, Sri Lankans love to eat bananas. My father would eat a whole about 10 bananas. So people love bananas and pepper. And the other thing is some of these drugs, especially the DPP-4 inhibitors like sitagliptin and epagliflozin, those type of SGLT2 inhibitors, they cause constipation. So people they eat a lot of fruits because they are getting constipated. But that will increase their sugar level. So, you have to ask them to eat 1 or 2 bananas for a day. So that's what I tell. This is not on a guideline, but practically these are the things that I use. Then the other thing everyone is drinking, these Nestle malt Horlicks and all these other preparations because the milk packets were not there for some time. So basically those things have high sugars, so they need to avoid. So I'm not against drinking milk actually, because we get calcium, because I also deal, endocrine deals with calcium. So most of the calcium we get is from the dairy products. So I tell, okay, you can drink milk, even though the milk, but don't put sugar to it. So don't put all this Nestle malt, Horlicks and all of those things, but you just drink it without sugar or this sweet stuff.
Next question is a practical question, madam. In the ETU, which levels of sugar do we really need to start soluble insulin on in an asymptomatic patient who is stable?
So I don't know why you need to start, why a stable patient is in an ETU. So it depends on, I think it's difficult for me to answer this question. So why is a stable patient in an ETU? So if someone is ill, particularly if someone is ill, then you might avoid things like SGLT2 inhibitors because it causes dehydration. Then you might avoid metformin because lactic acidosis, even though lactic acidosis is quite rare, people who are septic, having low blood pressures, they can develop lactic acidosis due to their underlying condition, which may be worsened by the metformin. So in that case, we will not give metformin. So I'm sorry, I don't think I'm giving you a good answer for your question, but it's not clear for me. So it depends on the patient's scenario. I can't give a broad answer for that question, I suppose.
Final question, madam. How to interpret HbA1c of a polycythemic patient?
Okay, so polycythemia, I haven't read on this polycythemia and HbA1c. I have to think and answer. We know that anemia will affect HbA1c, so definitely polycythemia will have an effect. So anemia, the cause for anemia affects the HbA1c, whether HbA1c is going to be falsely high or low. So I'm not sure actually whether polycythemia, what effect. I have to read on that.
Thank you very much, madam. I think that's all for today. It was a very insightful and very practical lecture for most of our viewers, and they had a lot of questions concerning this. We warmly thank you for coming today and spending this Sunday morning with us and taking the time to answer our many questions. For all our viewers, we have posted the link for the application to receive your CPD e-certificate on our chat box. Please fill it so that you can receive your e-certificate. We will be also posting this lecture on our official YouTube channel. Please subscribe for it. It will be available in a few days. You can also view our past lectures through our Shri official YouTube channel. Thank you very much for being very interactive and participating this morning. Hope you all have a beautiful Sunday. Thank you.
Thank you so much.